Hey everyone, Jeff Horowitz with Dentist in the Know, and sitting with me is one of my favorite people in the industry. Asked him to stop by, and he was the first guy to run by here and say, hey, I want to talk to my buddy. I'm with Dr. Thomas Dudney. So Thomas, we all know him. We used to be in the same group where we lectured together, got to know you really well through the Catapult group.
Right.
And I just want to hear what you're doing now. Tell us what's going on in the life of Tom Dudney, because this is a really accomplished dentist, folks. So,
I don't know.
Yeah.
That's pretty kind. Yeah, I just happened to be walking by the neighborhood and said, oh, look, there's Jeff. Thought I'd stop in and say hello. Unlike you, I'm still in Catapult because I haven't progressed up the chain, so to speak. I haven't found new exciting adventures.
I don't know if the direction is up or not. But
sure it is.
Of course that's up for debate.
But, still lecturing. I'm actually lecturing here tomorrow. Excited.
Oh, great.
I love this meeting, by the way.
Yeah,
so,
I do too.
I come to Chicago Midwinter. I've been coming to this meeting for years, and I come every year and always get excited if I'm lecturing because I really like being here for this meeting. I don't love Chicago in the wintertime. But, companies I work with,
How
people
often are you outside?
Yeah. Well, you're not. You're not. You're in a car,
in the
you
Uber,
get
out
out,
of
you
the
walk
Uber.
in.
Yeah.
So, but still, I mean, this beautiful here in spring. Oh my God, Chicago in spring, gorgeous city. But I love lecturing here. I love.
What are you lecturing on?
Tomorrow morning, I'm lecturing on indirect restorative materials, adhesives, and cements. I call it MAC dentistry.
Yeah.
The MAC, materials, adhesives, cements.
Oh, that's cool.
So MAC dentistry, the what, when, how, and why of indirect restorative materials, adhesives, cements. And then in the afternoon, I'm lecturing on a systematic approach to diagnosing, treating the worn dentition. Something I know you know a lot about.
Talking my jam.
Sleep dentistry and all. It's something we don't. And I've learned this, Jeff, which is kind of interesting that. We see so there's different wear patterns. And one of the wear patterns is protrusive wear. It's okay if we just get into stuff like dentistry,
absolutely.
Right? Okay.
Yeah, and
I didn't know if I was getting ahead.
No,
what's going on in your life.
If we can give them some clinical tidbits along the way, that's awesome.
So one of the wear patterns is we call protrusive wear. So, with protrusive, you slide your lower jaw forward. So what you look for, clinical signs of protrusive wear pattern, is incisal edges are flat and even. I know you know all this. So what I didn't know when I started lecturing on wear, I said it really opened my eyes because I started learning things. I started seeing things I never saw before. Yeah. It's really kind of an interesting story. If it's okay, I'll share it with you.
No, please.
But so anyway, protrusive wear, what we see, especially in young people, why would they have a protrusive wear pattern if they're really young and there's not a lot of stress or something in their life? And it could be an airway obstruction. It could be something to make them slide their jaw forward in order to be able to breathe better.
Right.
So we look for these signs now in people with protrusive wear. So I kind of talk about that and introduce that, in the lecture. So it's one of the things I'll be lecturing about. But
do you find that some of that is also iatrogenic, i.e. orthodontics, where maybe teeth are retracted too much, or veneers,
absolutely,
or 3/4 crowns,
you close that
the envelope of function,
where they feel constricted. In fact, I show a case where a guy's got wear on just one side. He's a right side bruxer. He bruxes laterally to the right side. Left side, right side, 6, 7, 8 are worn pretty bad. Yeah. Left side, no wear at all. And why would somebody brush to the right side? Well, then you look at the occlusal view and you see that the arch form is constricted on that side. So he probably felt like he had to push against that side. But absolutely, we see it could be iatrogenic, meaning it can be caused by us, or it can just be the way their teeth developed or erupted in. There's a constricted envelope that causes wear patterns. But certainly breathing. And, and the other thing, too, is that, of course, early on, I would treat anybody. They had a pulse, they walked in the door, they were a patient as far as now I don't. I love children. I have 6 grandchildren I dearly love, but I don't love treating children. Okay. So we don't treat a lot of children in our practice, but early on I did. And I'd have parents tell me, I don't understand why little Susie's grinding her teeth. I walk by her room at night and I can hear her grinding her teeth. Why would a 5-year-old be grinding their teeth? But I never realized it could be an airway obstruction. Now I understand, but I can't. I'm waiting to get asked that question again. Right. But I'm not treating children, so I don't really. But my first response would be, well, you need to get her, evaluated. Maybe a sleep study or something. It could be adenoids, could be tonsils, it could be some kind of obstruction.
But the old thinking was they'll outgrow it, but at what expense?
Yes,
right?
exactly. And what habits may be formed.
Right.
So anyway, I'm learning so much more as a and the way it happened, I'll tell you really, because it's a really long story. I'd done this case. It was a GERD case, and so a gastric reflux case. But it was just the acid, regurgitated acid had destroyed her incisors. And so she had short teeth, had wear, unattractive smile. She comes in, she wants to do, well, at the time, we're teaching veneer courses, I'm teaching aesthetics. So I'm doing this case and it turned out really good. We had to open the bite and all that kind of stuff. And it turned out nice. So I published the case. Well, I get this call from a dentist who's, he's the guy that's getting the speakers for the Florida Dental Association meeting. And he says, hey, I saw your article. I'd like you to do a lecture for us on tooth wear. And he goes, do you lecture on wear? And I said, yes, because I want to do it. I'd never lectured on wear or anything. But here's the thing, Jeff, sometimes things work out and it's a silver lining and it works out good because I said yes, not knowing what I was doing at the moment. And he says, it's next year. I said, I can get something. It made me start looking. And, it was several years ago, but when you start looking, you start seeing.
I actually love what you're saying, because this is one of the things that I think has made me a better dentist as well, is kind of pushing the envelope of things that you're willing to teach.
Yes.
Because in order to teach it, you better damn well know it, right?
You better know
so it almost forces you to really master the subject,
right?
And so I've had a few things where I've kind of stepped outside of my comfort zone to teach, but I ended up being a better dentist for it because of what I had to learn to do it.
100%.
Yeah.
And the thing is that the hardest thing to do, I think, is teach another dentist. Because it's not you really have to know what you're talking about, and you really have to study it, and it makes you want to be better at what you do. So I immediately went to my hygienist and I told him, I said, anything that even looks like where I want to get pictures of it, I had to start accumulating cases.
Yeah.
And so I instantly started looking, and I would go in and check every hygiene patient. I'm looking for any signs of any wear at all in any case we did. And then I go back through my library of cases we had done, and I'm going, hey, you know what? Some of these cases were wear. I'm thinking, hey, I could incorporate these, maybe, things like that, bite opening cases.
I don't know if you've experienced this. So I have all of these little folders with different types of cases, but I would kind of pigeonhole a case into this is an ortho case, and then I can't ever find it when I'm looking at it as a, TMJ or Airway.
But it turned out okay. And the end, the short end of the story, which is a longer story, is that I started doing this lecture on wear, and it's something that meetings like, because not a lot of dentists lecture on restoring the wear. Like my good buddy Bob Argis, he lectures on this. He's got a lecture on wear, but there aren't a lot of people out there. Frank Spear is the master. He is the best. I mean, bar none. I learned most of what I talk about. I learned from, and I say that when I lecture. I'm not a guru. I've just learned from smart people.
Yeah,
and I've taken that but Frank, all the stuff that he talked about with wear and treating the worn dentition and, designing a occlusal scheme that fits the grinding patterns of the patient, all these kind of things that are so helpful and so common sense.
Yeah.
When do you open bite? What's the reason for opening a bite? He tells you, you do it to improve aesthetics, improve occlusal function. All the reasons for opening, all the things that he teaches are so beneficial, and they're very common sense. Open the bite. When you open the bite, you don't use it by a measurement. Open the bite the least amount necessary to satisfy the section aesthetic and functional goals.
Right.
Those are the kind of common sense things that really kind of strike a chord with me. So I learned a lot from him, but I've enjoyed doing the lecture, I think, because not everybody's lecturing on that. And
so you know what I want to pivot and talk a little bit about your lecture that's coming up tomorrow here at Chicago Midwinter.
Yeah.
So you're talking a lot about indirect restorative cementation.
Yep.
What are some of the I guess the biggest mistakes or misconceptions about cementation in the industry right now?
Okay, so here's the thing. That's a great question. And so first off, you got to decide, are you going to cement or are you going to bond? Okay, they're two entirely different procedures. And we all love to cement. And the reason we like to cement is because you don't treat the tooth or the restoration. So if you don't have to do anything to the tooth other than rinse and dry it, you don't have to do anything to the restoration other than rinse and dry it, just put the cement in the tooth, put the crown on the tooth. That's pretty simple. So we call that cement. It's what I call conventional cementation, meaning you don't treat the tooth or the restoration. Adhesive bonding, with a resin cement, that's a different situation because now you're introducing a lot of variables. Okay, you're having to treat the tooth and treat the restoration. So with cementing, with adhesive bonding, you want to isolate, especially if you're etching when you bond is part of it because you're going to open dental tubules. So you want to dry field, you want to isolate, you have to do the right steps. There's a lot of steps that are introduced as far as how you treat the tooth, what primers you're going to use on the tooth, what bonding agent are you going to use? For me personally, it's a universal adhesive. Universal adhesives have been one of the greatest introductions to dentistry because I don't care if you do self-etch, selective etch, or total etch technique, you can use a universal adhesive. Whereas with total etch, like 4th and 5th generation, you can't use that for everything. And self-etch primers, like 6th generation, you can't use that for all kind of etching modes.
So that's where I kind of see a little bit of lack of a better term, abuse is in some of these self-etching products and misuse. What are some of the contraindications to using some of these self-etching adhesive cements? Because I think they are way overused.
Okay, so self-etching adhesive cements are great when you have a retentive preparation. All it does is just gives you a little, you will get some bonded tooth. If you have a retentive preparation, I mean, ideally what we'd like in a crown preparation is 4 millimeters of axial wall height and 6 to 8 degrees of taper. If you have that, the crown's going to stay on pretty much any cement you use, okay? But if you have a less retentive prep, and you're kind of in the middle, there's no retention or very little retention, that's where you need to bond. And there's a less retentive prep, then possibly a self-adhesive cement could give you a little bit of extra adherence to the tooth. It could be beneficial. But most of the time, the self-adhesive cements, if your cement doesn't need, if you've got a good retentive prep, it doesn't really need to be self-adhesive. There's other benefits to what I call a conventional cement nowadays, and then we get into bioactivity and ion release and recharge, those type of things. So if you have a conventional cement, meaning you don't treat the tooth of the restoration, you just put your cement in there, and some of them are resin modified type glass ionomer type cement. They have glass ionomers, they have calcium release, things like that. Some of these newer cements can be extremely beneficial because you are going to get some adhesion to the tooth, but the ion release and the possibility of them being, forming hydroxyapatite and things like this, being antimicrobial, antibacterial, your marginal integrity could be greatly enhanced by using one of these cements. This is what I'm saying. This is a simple cement, but if we're bonding something where we need retention, say, let's use porcelain veneer. Okay, a porcelain veneer is a non-retentive restoration, so we're going to have to bond that restoration. So if it's thin enough, we're going to use a light cure resin cement because I want unlimited working time. And if I'm doing 10 veneers, I can bond all 10 veneers because I have a light cure cement. But if you have a thicker restoration, you might want a dual cure resin cement. So you'll say a crown that's non-retentive, I may bond that on with a dual cure resin cement. But I'm going to treat the tooth. We know this for a fact. Self-etching primers work on dentin well. You can get good bond strengths to dentin with self-etching primers. But if you're bonding to enamel, you really need to use an etch and rinse technique. Okay, so that's why if you have some dentin and some enamel, you want to just etch the enamel. You don't really need to etch dentin. You can, especially with a universal adhesive.
Yeah, it seems like the move is, there was a while where everyone's saying, etch everything. It really seems like it's moved away from that.
Yeah, it's because we realize it's not necessary. Selective etch, because you don't really need to etch dentin to get good bond to it. So why open tubules if unnecessarily if you don't need to? But if you are going to etch dentin, that tooth needs to be isolated.
Yeah, it does. It becomes more labor intensive and technique sensitive.
Very technique. And there are other factors too. You got to understand when you etch a tooth and you're etching dentin, you have to be very careful how long the etch is on the dentin, and you have to be very careful how long you dry it, and you have to be very careful to make sure your primer, when it's being applied, you put that primer on there enough, because the great thing about self-etching primers, you're etching and priming at the same time. So it's self-limiting. You can't etch deeper than you can prime. But when you etch and rinse and then you put a primer on or a universal adhesive on, you can etch deeper than you can prime. So you got to be careful. So there's all these steps. I'm just trying to give a basic idea of understanding that there's multiple steps you have to know about in drying. Like, you got to evaporate the solvent. If you just do a couple of quick air blasts, you haven't evaporated all the water in the solvent, then that's going to affect bond strengths and long-term bond.
Right.
So there's factors like that you have to understand.
I think there's, one of the problems that we have is we're always looking for that one product that does everything. And that just cannot be in the cementation world.
So cements, this is what I say. Now, for adhesives, a beautiful universal adhesive, I can use anything. I have not used anything over the last 11 years, almost 12 years, anything but universal adhesive. I have not purchased any product because I can use it for everything, no matter what I'm doing. When I'm bonding something on and I need an adhesive, whether it's direct or indirect, I use a universal adhesive. But with cements, I believe you need a conventional cement. That's one that you don't treat the tooth of the restoration. I like ion-releasing cements, but resin-modified glass ionomers are great, as we talked about yesterday. And you can have great products there. Glass ionomer cements can be good. It's just their physical properties aren't great. That's why they've been reinforced with resin to increase their physical properties and still have all the other benefits of glass ionomers. But you need resin cements for bonding. So you can use these self-adhesive resin cements, or you can use resin-modified glass ionomers for conventional cementation. But if you're bonding a veneer, you need a light cure resin cement, okay? If you're bonding a crown with no retention, you need a dual cure resin cement, okay? Because you want the highest bond strengths. With a self-adhesive resin cement, you might get 5 to 8 megapascals, but with a universal adhesive, a bonding tech, whether you use selective etch or total etch, and you use a dual cure resin cement, you might get 28 to 30 megapascals. So you're going to get much higher bonds doing it that way. So that's the reason. But I think you need at least 3 cements. You need a conventional cement, you need a light cure resin cement, and you need a dual cure resin cement. But that pretty much covers everything. But for somebody to say, a lot of times now manufacturers are saying that a dual cure resin cement is a universal cement because you can use it for anything. Technically now, because they've eliminated the tertiary amines that cause darkening over time, you can use it for a veneer. My only problem with that is if you're sheeting multiple veneers, I don't want a dual cure cement. I want more working time. I can only do 2 or 3 at a time. But I want to see, if I'm doing 10 veneers, I want to put them all in at the same time with a light cure cement. So for me personally, I want a light cure cement and a dual cure cement. Plus, why would I want to use a dual cure resin cement if I'm cementing a retentive crown? I don't think you need to do that. I would like to have what I call conventional cements that have ion release and possibly ion release and recharge that could be extremely beneficial.
Yeah, I agree with you. And I think the big takeaway from that is just know how retentive your prep is.
Exactly.
Just
it is.
Understand you need that axial wall height, 4 millimeters. And
most dentists know when a prep is retentive. And if you're trying on your crown, you put it on, it falls off. Some crown, you ever try a crown on and just trying it on and you can't get it off?
Actually,
that's a retentive prep.
After 32 years of practice, actually had my first patient that I had to take to the walk-in clinic for an X-ray. I had one swallowed just a couple of weeks ago.
But I feel like implant abutments sometimes are highly retentive because I've tried a crown on an implant abutment, I can't get the crown off. They're really hard to get off. Or I try a crown on a prep tooth, and I'm having a hard time getting that crown off, then I know that prep's retentive. But if I put the crown on, I got to hold it with my finger. And as soon as I let my finger go, the crown falls off. I may want to bond that crown.
That's great practical advice. But we're running short on time.
I'm sorry.
No. It's great. I mean, I love this clinical information. You never know what direction some of these things are going to go into, but always love talking to you.
I would like to add one last thing. I think it's very important. And that is for dentists out there that might hear this, if you do have a retentive prep, don't bond Emax, don't bond zirconia, okay? Because somebody's going to come along down the line somewhere. They're going to have to take that crown off. If you can cement it, cement it. If you have to bond it, but only bond when you need to bond. Because zirconia crowns and Emax crowns that are bonded on, extremely difficult to get off.
And why would you when you can use something with bioactivity?
Exactly. And we can't, bioactivity could be another whole talk because it's coming. And it's going to be, I think it's the future of dentistry, I believe. Anyway,
well, great ending point. What's next for Dr. Tom Dudney? Practicing still how many days a week?
Yeah, when I'm in town, I practice 3.5 days a week, something like that. If I'm
still
trying,
hard
like
at
this
it.
week, it was 2 because I left Wednesday, like you. But yeah, I still practicing keeps me sharp for lecturing, and lecturing keeps me sharp for practicing. And I still like when I'm doing a lot of aesthetics. When you do aesthetics, it's fun, it's rewarding, so you don't get burned out.
Yeah.
If it's just drill, fill, and bill, that old kind of stuff, that can wear you out, wear you down. But when you're creating smiles and helping people or restoring, worn dentitions, or rebuilding a bite or something, that's kind of rewarding. So yeah, I could do this for a while, and I love lecturing, and so that's kind of me.
And
for
it's
the future.
great hanging out at these things.
I love seeing my friends.
It's like a big homecoming.
Yeah, absolutely. I look forward to it. I feel sorry for dentists that don't get to have some of this in their life.
I agree.
Because it's so, and for young dentists out there that might hear this, go to meetings. You're going to have fun. You're going to learn more. And the camaraderie is great. It's what dentists is all about.
Yeah, I agree. Couldn't have been said better. Tom Dudney.
Thank you, Jeff.
Great to see you.
Enjoyed
again.
it. You guys are great. I
man,
love what you are doing. You and Chad and Jennifer are awesome.
Well, thank you so much.
All
It's
right.
great to see you.
Okay.
All right.
My
Dentist
pleasure.
in the Know, Dr. Tom Dudney here at the Chicago Midwinter. Have a great day, everyone.